So it's always, when you're like following the lab team, it's always easy. I don't have to do anything actually. But anyway, so we'll show a couple of videos just to go and with our protocol again, very similar with the night before, sambal prep, stockings, flow-trans, epidural GA, ERAS protocols. So ports are again very similar to an anterior section for an intersphincteric. So I'm going to show two videos. One is into 2 times fast, and one is almost in a normal pace. So let's see. So this is a TME plane. We're going to go down into the pelvic floor. So again, this is with the XI. The pictures are slightly duller compared to the SI. I like the SI pictures, but again, the left arm is pushing on the back of the mesorectum, lifting up and exposing that nice angel hair fibers. I think that's the secret for your TME. If you get it right, you can see the how easily the articulation of your wristed instruments are helping to dissect out that plane. It could be post chemorad, it could be stuck, but just staying there in the plane, just close to the rectum, at the junction where the fibers and the rectum are attaching. I think it's very important to stay in that exact area all through, and use your tip as your paintbrush again. So the posterior, as I said, vessels, posterior dissection, right side, anterior left. So once you standardize your procedure, you just do it however difficult, however simple it is, just follow the same 4 or 5 steps, and in due course it becomes a straightforward operation. So once you do that posteriorly, as far as you go, when you do the lateral sides, you'll see how much dissection already done. So you've done the right side, now you're going on to the left side. You've already dissected and taken the vessels. You can see the gas going in. And once you open up that window, you've already done the dissection medial to lateral earlier. So you just double check, making sure that the ureter and the gonadals are away. So you can see, because of the posterior dissection, it just becomes much simpler. So you just take the left lateral so easily, and it's very quick. Again, as I was mentioning, I keep mentioning again and again, it's your left hand which does most of the operation for you. So again, you can see that nice angel hair fibers there. So keep, whenever you're lost, when it's all stuck, you just go to an easy area, start again, find those fibers, and then you connect the dots. As I said, this spot is about 2 centimeters in Pouch Douglas, 2 centimeters from where the rectum joins the peritoneum above, so that you get into that plane nicely. So again, as pass a straight needle, it's a ethalon to hike up the, and I find it extremely useful to do that, because it just opens up that anterior plane beautifully. So you can see it. So your denonvillus fascia is that. This is the denonvillus. And I think you should get into that nice flimsy tissue again over here. If you see the so you continue the dissection up to the pelvic floor. Again, traction, counter traction. Your assistants, in my case, the laparoscopic instruments are your hands. You're hiking up the rectum. So again, those nice fibers are there. They are, God's just given those fibers just to guide the rectal cancer surgeon. If not for that, would struggle. So follow that, and you'll be absolutely fine. It's a completely avascular plane, and it just makes the operation so much simpler. You can see it's everywhere, all around. So you can see the pelvic floor muscles are all starting to show up now there. So you're really getting into as low as possible. And I think this is where it gets challenging, either lap or robotic, to get those views, to maintain the vision, to have a stable platform, to see that groove. So it's the anterior, which is last few attachments are coming off. So there's a left pelvic floor there. So now we're getting posteriorly, you need to. So this is the left pelvic, sorry. It's a little swab which I always have around to mop and clean. They said no suction or wash. So you can see the pelvic floor muscles right and left, and this is where you're getting into the intersphincteric groove, right here. So that's the groove. You need to sort of carry it further as far as down as possible. And you carry the dissection anteriorly and the sides. You can see it's all, the muscles are dipping in, and you're getting into that space there. So the right external, the pelvic floor muscles become the external sphincter. You're getting into that groove between the internal and external sphincter there. So this is a stapled low cholanal anastomosis. So this is coming through the 12 millimeter port. I usually use a 45 Covidian because in the narrow male pelvis you can get the angulation. You could use the lever on the external. I struggle a bit with the J&J one. So you can get really much convenient to get the stapler. So you hike up the rectum and you get your instrument as low as possible. And if it's difficult, you can always go, put a suprapubic port and do it. But usually you're able to achieve it. We may have to remove the right arm out because it gets in the way of getting the stapler in. So, and this is we don't use a robotic stapler. We just, it's not available in India. So we just use conventional ones. Okay, so that's one. So this is another dissection, slowed down, but I'll just rush through it just to show. So again, you're getting into that space where, you're teasing off those tissues in. So you're just coning it onto the rectal tube into the intersphincterix phase. So posteriorly again, it's, you're getting back into that same groove in the pelvic floor muscles and the and that's, I think this is where it gets really useful. And this, and as I said, the XI, you have the 30-degree camera, look up and down with the flick of a button. So the SI, you need to get it out and turn it around. With the XI, you just press the button. It goes. Particularly if you're doing this, where you want to look up rather than looking down. It's just so convenient. So those are the muscles. That's the intersphincterix phase. We're just opening it up as low as possible, and when you come from the bottom and doing a perineal dissection, it's only 1.5 centimeters or 2 to when you do the intersphincter dissection on the bottom to reach up. Again, such stable views, clean, you don't suffer as much with fogging. But if you have the air sealant from ConMed, I think it really helps, particularly in with this low resections. So that's almost over. So again, perineal dissection, we use a Lone Star, and then you do the intersphincter dissection. I think Dave's shown a brilliant video, so I'm not going to repeat that. I had a video from Emre, which is beautiful, but I'll probably skip that because of time. And then the colons are extracted, and depending on length, you do a straight anastomosis or a J-part. Thank you.